So I've been asked by Dr. Vaibhav and team to talk about different types of robotic systems. I'm coming from the UK. I'm originally from Belgium, but I work and practice in Wales, part of the United Kingdom, and see my affiliations here. So let's talk about robotic systems. So you got the apples and the oranges. So different systems, different outputs, different inputs. And what we really want is we want to have a system working like this because we got loads of patients out there. In some countries, there's longer wait lists than others. I have to say that I'm very ashamed of my wait list now. Nowadays, it's 4 years wait to have a hip replacement or knee replacement in the NHS in Wales. But what the robotics should be able to do, it should enhance the ability to reproduce alignment and restore normal kinematics. And that's both in hips as well as in knees, and maybe in the future in shoulders as well. There's quite a lot of written about robotic technology, and the previous speaker, which I unfortunately had to bump into, was already talking about PSI and robotic systems, but there's quite a lot of written of robotics already. Current concepts reviews in the Secret Journal, in the Journal of Bone and Joint Surgery, the American version, and in the Indian Journal of Orthopedics presented by Dr. Bagari as well. But what is the problem? The problem is that robots are not all the same. There are different types of robots, and I do believe that they can only get better. And they will only get better by us using them and by using artificial intelligence in the future. So why do we need robots? Well, first of all, the outcomes might not be as good as we want to. We all are aware that 80% of the knee replacements are happy, but 20% might not be that happy. The expectations of the patients, they want to do more and more and more and quicker and quicker and quicker. We also know that the longevity of the joint replacements are not forever and ever. The forever implant doesn't exist, although we're getting pretty sure at the moment. The demand is increasing. The training at the moment is a little bit more difficult, and especially our colleagues that have gone through COVID in Europe and USA have had a little bit of a gap in their training. We all want more accuracy, and every surgeon, that's me included, will have an off day. So we really want to make sure that we do our best for the patient every day. So what are the different platforms? So first of all, you got open versus closed. So open means that you can use whatever implant you want versus a closed system. So the implant follows the robot follows the implant. So you got autonomy differences like active, semi-active, or passive, mechanism of cutting, burr versus sew, direct versus indirect. So some robots do cut the bone, and some other robots provide the placement of the jigs. And then image versus imageless. And let's go into more detail about it. So open versus closed systems. So many have started as an open system and then were acquired by the big companies. And my colleague already said, companies are making money out of us trying to sell the implants through their robotic systems. But open systems, they can accommodate a wide variety of prosthetic designs. They have got a lack of in-depth biomechanical kinematic data, so that is a bit of a disadvantage. And T-Solution Think Surgical is one of them as an example. Then closed systems, accommodation of limited variety of prosthetic designs, like linked to single prosthetic company, good biomechanical kinematic data, and company support. And I think for you to be aware of the Navio system, in theory, can do an Oxford knee as well. It's made for that, but they won't allow you to do it. So it's a closed open system. So autonomy, so you got passive and the constant and direct supervision of the surgeon. Semi-active systems requires a surgeon active involvement, and then really active system, which I had the opportunity to do when I was a young trainee in 1999. So we had a robot at that stage in Pallenberg in Belgium, Leuven, where we did a couple of cases with, and that was an absolute disaster. The robot didn't know what he was doing, and we had more soft tissue damage than we had proper bone cuts. So direct versus indirect. So direct, the instrument attached to the robotic arm, like a saw, a mill, or a burr, haptic boundary control. And indirect is a cutting block like the ROSA system attached to the robotic arm. The robots do not touch the bone, and then handheld traditional tools. Then you got the boundary control, the haptic control, and the autonomous control. So presumably that's already been discussed this morning, so I don't really want to repeat too much. But what I really want to talk about is the image-based versus image-less. So you have to have a plan. And whether you make that plan preoperative and corrected intraoperative, but you need to have a plan. And without a plan, there's no execution. And then the platform performs the operative procedure. So if you have an image-based system, you've got a pre-op plan combined with an intraop plan, because you need to check it intraoperatively. And as my colleague was talking about, you have to check your your alignment, you have to check your balancing, you have to check your ligament status, and this is something that you always have to do to when you use a robot, and especially make a robot is very specific for that, and then you can do the operative procedure. But how do you make your preoperative plan? So you can make that on CT, MRI scan based, or plain radiographs. And every company has got his own patent on it, so you can't use one program with the other program, so the CT scans especially. So they really provide you the actual geometry of the patients. So you can determine the size of the patients, you can determine the depth and location of the section, reaming, target the alignment, target the deformity, and do an anatomical reconstruction using offset version in hip replacements and slope rotation offset knee replacements. And then it also can suggest you something about osteophyte resection. It considers a preoperative advanced planning and a predicted implant choice, and usually that predicted implant choice doesn't change, but the alignment might change if you're just add the ligament balancing into it. So it guides the actions during surgery based on an individual pre-op defined and intraoperative checked anatomy. So an image-less system is a little bit more simple because you don't have to have all this before. So it maps, it registers the surfaces and the landmarks, and then you provide the actual geometry of the patient. So it uses some algorithms to make sure that you know exactly where the patient is, exactly where the HKA is in knee replacements. So you can still determine the size of the implants, the depth and location of resection, reaming, target alignments, deformity correction. However, it does not take into consideration some extra articular deformities if they're too far away from the joint. And once again, anatomy reconstruction can be done as well. It allows for intraoperative planning and predictive implant choice and alignments, guides action during surgery, but it relies very heavily on the accuracy of registration. So in not Queen's English, they say shit in, shit out. So if you do your probing very, very poorly, then you might have your implants all over the place. So in diagram form, so this is how it works. So the top is the image-based and the bottom is the image-less system. It takes a little bit longer time if you do an image-based system, but I do believe it's a little bit more accurate. So what are the pros and the cons? So the questions you have to ask is, where is the accuracy? And what do you need? What additional information is available on the imaging? Do you need to have that additional information? And what about the special cases? The cases where you've got an extra articular deformity. So the negatives about having an image-based system is that there is an additional cost. There is some timing because DCTs, MRI scans will go out of date, and some companies just limit your 3 months timing for that. You've got the extra radiation for the patients. What to do with incidental findings? They're not very frequent, but they do happen. The time efficiency is a con, and patented technology. So you can't use a CT scan for a patient from one company and do it then just say, oh, I've changed my provider, I'm now going to do the same with a different company. It doesn't work. The pros are you've got the extra accuracy. You can correct for extra articular deformities. It's a double check. It's more personalized in my view. It improves the preoperative planning, and we talk about robotics, but in my view, quite a lot of robotics and quite a lot of what you're doing with your robotic systems is the planning preoperatively, something that our younger colleagues have forgotten about. Before you do the surgery, before you get your knife in your hand, do you know what you're doing? The traditional system with having a 2D plain X-ray of a pelvis and templating and trying to predict what implants you're going to use, it's a forgotten art in some of my younger colleagues, and I do think this is badly wrong. With the robotic and pre-op CT checks, you really know what you're doing, you know where your osteophytes are, you know how deep you go, and I think part of the Mako Racer study might allude to that, as that preoperative planning with the CT scan might really help. And once again, patent technology. So questions you have to ask, and in the break between the two talks when I was putting my talk on, some philosophical questions have been asked, and I think it's very important to ask yourself this question, especially the younger colleagues, is what is the target? What are we aiming for? Is it the same target for everyone? And what are the tolerances? How far can we go? And I think I'll talk about it later on. But Mohit Bhandari, we will see virtually on Sunday. If I don't know where I'm going, the robot will come with me. That's what he said. So just make sure that you guide the robot to the right direction. And is this all going to help with the patient selection? Will the patient help from the intervention? This is something that the robot will not answer for you. So wrong indication, wrong outcome once again. So with everything, the devil is in the detail. So the first surgical robot, Puma 200, accuracy within 0.05 millimeters, safety and versatility just for CT-guided biopsies, a great intervention for our neurosurgeons. But within orthopedics, you know, the accuracy of arthroplasty will be certainly a combination of advanced image technology and robotics. But a little word of caution, you know, all of this, are we doing it the right way? You know, are we just putting the horse in front of the cart, or the cart in front of the horse here? So we really need to make sure that everything we introduce within orthopedics is done using the stepwise introduction as presented by Henrik Malko from Denmark and Sweden now. So in conclusion, there are different platforms, you know, image-based and image-less. They've both got their pros and the cons. You need to understand the limitations and the advantages of each system and then decide what you want to use. There's nothing wrong with still doing the classical checks. And if I use a robot for my hip replacements, I will still use the traditional impactor just to make sure that the implant is well fixed and well seated. But I will also check whether I would have put it in there if I would have done it without robotics. And with the knee, exactly the same. I will use a drop rod or an extra articular alignment guide just to make sure that I'm not all over the place. I've been caught once and I will not do it again where my x-ray looks far worse than I've ever done using a robotic technique. So in conclusion, the technology is certainly here to stay. There are still many unknowns, and I think the more we use them, the more data we get, the less the unknowns will become. And it's very difficult to compare the outcomes of the different platforms unless they become open systems. And I think in the future, that's what we want to achieve, because some people might say the best implant hasn't got the best robot with it. And we maybe, you know, if once in the future, if everything becomes free and available, we might have the best implant with the best robotic system. And that will help our patients big time. Thank you very much for your attention.